record. Hi, everyone. Hope you're all having a great day. And welcome to our live session today. I'm going to be going over a quick startup presentation and welcome you all and introduce you to our program and kind of what we're all about. And then you can see some various opportunities that we might have for you. And if you've previously attended the shadowing, you've probably seen this PowerPoint, but no worries there. It's always nice to have a refresher. We do request that everyone mute themselves right now. There probably will be a bit of time at the end during the Q&A. If you do want to unmute yourself, that's welcome. But for now, just so we have all of everyone's attention and we don't have that background noise of random people talking, it would be nice to make sure that you're muted. So we are going to continue here. So we're Pre-Health Shadowing. We're an internationally student-led and women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, whether that's pre-health or even different degree backgrounds. We don't necessarily always have pre-health. It's just what we're centered on. Sometimes we have people that are still in environmental sciences and those backgrounds as well. You can always check out our YouTube video and see kind of where those backgrounds have been. My name is Kira. I'm the session host today, and I'm also a volunteer at Real Shadowing. And I want to thank you all for coming today. And let's get started. So let me minimize that. Just so you know, we do have closed captioning for anyone that needs that accommodation. And if you have any ideas on how we can make our sessions more accessible, or if there's any problems with the closed captioning, we're always happy to know any of that information. We don't always have access to look through all of that, so it's always nice when other people have ideas or can look through that as well. And you can email us at info@prehealthshadowing.com. There's settings available at the bottom of your screen, and it's through the Zoom actual website. If for some reason you don't get the closed captioning or there's some kind of problem with that, you can also email us and we can send you a transcript of this recording, and then you can go through that. I know that's a little bit of annoying, so hopefully the closed captions work for you. We are always looking for ways to be more inclusive though, so you can have us contacted or keep us in your contacts so that we don't go to your spam if we do reply to your email. Sometimes that happens and that's never fun. You can also join our email list so you never miss one of our sessions. And that is also through info@prehealthshadowing.com, or you can go on our website, and if you join any of the sessions, you usually also get onto the info@prehealthshadowing.com website. So if you want to stay in our loop, we also have Instagram, TikTok, X, which is Twitter. We'll never get used to that. We also have YouTube, and we also have LinkedIn if you want to look through those as well. Just if you want to stay in our loop and kind of see. And again, you can join our email list. That also keeps you in the loop as well. So since this is an international program, we always want to know where you're Zooming from. You can drop that in the chat. I'm calling from Los Angeles, California. Let's see if anyone else wants to say. Some people say stuff, some people don't. I'm curious. We usually get a lot of people from the East Coast, so it's always nice to, oh wow, someone's from Qatar. I have always wanted to go. I've seen such beautiful pictures of there. I don't think we've ever had someone from outside of the Americas. New Jersey. Well, people will probably keep dropping in the chat. I'm very curious. So if you want to keep doing that, I'm always happy to look through that later on. So we do have some wonderful opportunities for you guys if you're interested in being a part of our pre-health shadowing. You can register as a volunteer on our website. It's 100% remote. We do occasionally have events and things in person. So if you are looking for some of those, keep a lookout. We do have a Slack channel, and those get posted on there fairly frequently if we have them. I know that those are very few though. We do usually only have 100% remote, which is very nice because it works with your schedule. So you don't need to have specific times that you meet. If you want to do live sessions like what we're doing right now, then you would need to have availability during those times, but we have them all different times, all different days. So there's always something that works if you do want to be on the live sessions team. But speaking of that, we do have different roles. One of them is the leadership team. And this is also 100% remote. The leadership team has a very different roles. There's a nice list on the next one. And if you don't have a role that kind of fits or a skill set that fits any of these, you are also welcome to introduce your own role. Maybe you have a different idea of how you can help pre-health shadowing expand or get better. And then you can make your own roll up and see if that gets approved by our team. So we're always happy if you ever want to do that and be a bigger part in supporting PHS. So we would love to see, you in our network of student volunteers. One of our other things that we do is high school students. I don't know if there's anyone in high school in here, but if you are, we do offer somewhat of a leadership training program. This is mostly to help you with fundraising or creating a club on your campus. It is a great way to get more education and also educate others in your school on healthcare and see if that's something that they also want to do. You can also take this into going to college. You can make a club in your high school and then transfer that and also make a club at your university or your college. And that is all helped out through our program. We don't just throw you to the wolves, that we definitely help train you in how to do that and how to set everything up and work with you and establishing that so you're not on your own. So if you want to do that, you can also email us at info@prehealthshadowing.com and we're happy to kind of give you more information on that. We do have an AHTP, the high school training program, link on the website that will go through the program with you in a little bit more detail than these slides will give you. It's part of our mission to be diverse and promote diversity. So in order to do that, we do want to launch more pre-health shadowing diversity panels. And kind of highlight on topics like racial disparities, LGBTQ plus health, sexism education, anything that kind of makes us who we are in different diverse ways. So if you are interested in helping out and doing that, you can nominate someone who you think is inspiring and who has helped you kind of learn a different way of thinking about how we fit on this earth and where we are in the world. So if you want to do that, you can also email us at info@prehealthshadowing.com and you can tell us who it is that has inspired you. And then maybe we can get a panel going, which would be very exciting because I always love when we do those panels and host those. So last but not least, if you can donate, we are a free and accessible to everyone program, and we do run solely off of time and donations, time from the volunteers and donations from people that are watching our sessions, but also people that have been reached out to. So if you cannot donate, it'd be great for you to reach out to someone that maybe you think could donate to our program and help us out in organizing all of our things. We have our website does take time and money to put into, and also Zoom and all of our things that we use to host, especially for all of these sessions. But we also very much love any time you want to give. If you want to donate time, very happy for that. So last but not least, type your questions in the chat. Our co-hosts and our hosts will also be plugging those into a document. So don't worry about your question kind of getting bogged down with everyone else's questions. We do have those written out somewhere else, and then I can ask them at the end of this session. Or if you want, you can raise your hand at the end during the Q&A session, and I will let you unmute so that you can talk to the professional herself. And we can have that organized. So take good notes. We do have a post shadowing assessment that'll be available at the end to earn a digital certificate. I will be going over that in another slide at the end so that you guys can understand how to get that and where to go. So if you want to put your camera on, this is a great opportunity and time to put your camera on. We always love seeing everyone's face. It makes it a little bit more of a community type thing, but if you don't, no worries. So now I'd like to introduce Dr. Roy. I think I could just stop this. There you go. Thank you so much for your time, by the way.
No problem. Thank you. Appreciate it. So I'll go ahead and share my screen right now. Okay, hello everyone. My name is Mansi Roy, and I'm gonna speak about the role of audiologists in modern healthcare. Is everyone able to hear me? Okay. So if no one knows what audiology is, basically, I would say, like, imagine waking up one day and realizing that the world around you may be sounding different, or even the music doesn't have clarity, or you feel dizzy every time you move your head. Or if the parents with their newborns have a hearing loss, their joy will definitely turn into more worries because, it's a newborn, they can't hear. So, what would you do? For millions of people, these aren't just occasional experiences, they are daily life challenges. Um, okay, so here I go. And my name is Roy, Mansi Roy, and I'm a Doctor of Audiology student right now at Hofstra University in New York. I did my undergrad from India and I moved to US in 2022 to follow my passion for audiology. Why I chose this career? Because helping people hear is more than just a job. It's basically restores connection, emotions, and dignity. The moment when I see baby who can hear for the first time or the parent's face lit up, that's a life-changing and a rewarding opportunity for me and an achievement. Even when elderly individuals who often feel isolated because of their hearing loss, giving them back their ability to communicate brings them closer to their families. Hearing loss can even strain relationships, marriages, so helping them to hear their loved ones and can rebuild connections and change life. To be honest, it's a great opportunity. So, audiology is not only about just ears, it's about people, emotions, and restoring the sounds of life. So let's go with what is audiology. Audiology is the science of hearing, balance, and how the brain processes the sound. So we diagnose and treat the hearing loss, the tinnitus, and the balance disorders. We fit hearing aids, cochlear implants from infant through pediatric population. Also, sometimes the brain can interpret the sound, even though even though they have a normal hearing, the brain, when they interpret the sound, it's basically the brain is not understanding what the sound is meaning to. So that is something known as central auditory processing disorder. So in our profession, we have a wide area where you have these kind of disorders to deal with it. And also you need a certification for an intraoperative monitoring, which is basically in the OR, which I'll talk to you in the further slides. And you can also take a part in like forensic audiology, which evaluates your hearing loss for legal cases, like if it is a noise-induced hearing loss claims for the companies or medical malpractice cases, personal injury lawsuit, criminal investigations, and military and occupational testing. So this is what it's not only just testing the hearing, it's a lot of things you can do in this profession. So let me give a basic introduction of how the hearing works. So the sound waves enter through your outer ear. So this is the outer ear, this is the middle ear, and the snail-like structure is your cochlea. So the sound waves enter through the outer ear, which travels to your eardrum. Then it'll pass the vibration to your middle bones, the ossicles, and that will travel to your cochlea. So the cochlear hair cells will convert the vibrations into the electrical signals, and then that signals will travel through the auditory nerve to the brain where they can process the sound. So this is an audiogram. On my right side, this is an audiogram. The X's are the left and the circles are the right. So as you can see, like this is a declining thing. So this circles or the X's are called threshold. So threshold is nothing but this is where the person can hear the sound. So imagine this simple graph can get me an information about a person if they have a Meniere's disease or even if there is any acoustic neuroma with the confirmation of MRI. So this simple graph can get me information about the hearing health even in a medical setup. So even like when I was an undergrad, I was very much like thinking like, oh, this is just a simple graph, but that simple graph can lead so many hidden information. Even it can let us know if someone is at the verge of getting a hearing loss or not. So which is very much important for taking early intervention programs. So what are different kinds of hearing loss? So there can be a conductive loss. Conductive is nothing but when your outer ear or the middle ear, like your outer ear and the three bones in your middle ear, if they have any issues, then that will be a conductive hearing loss. When it goes to your cochlea, the inner nerve or the auditory nerve, that will be basically your sensory neural hearing loss. That means your hair cells of the ears is damaged, of the cochlea is damaged. It could be due to the noise exposure, aging, genetics, could be. But then there's also something as mixed hearing loss, which is combination of both conductive and the sensory neural. There are cases where we see congenital and acquired. Congenital is for the things which is present at the birth, which is often due to infections during the pregnancy, rubella, or some birth complications. And acquired is something which happens at a later stage. So this is basically for more adults or more teenagers, whereas congenital is for newborns. So when you have a congenital hearing loss, what's the basic thing? So there is a joint committee who says newborn hearing screening is like mandatory for all the hospitals. So once the newborn is born, we have to test their hearing, like how you do the basic, all the reflexes and everything. You also do a mandatory hearing test with an OAEs, which is a acoustic emission test, just to test their inner ears hair cells are functioning or not. And then also you do the ABR. If there is any issues, then you do a fully diagnostic test, but or else you see if the baby has passed, that's good. If it hasn't passed, what can be the early intervention for them? You fit with either hearing aids or cochlear implants or do a oral rehab, because from 1 to 3 years of age, it's very, very critical for the kid for their speech and language development. That's why the sooner you put these hearing aids or the sooner you give the oral rehab, the sooner the child is going to be able to participate in their regular life. I'm going to discuss two case studies. So this is a case study of a 34-year-old man who came with a complaint of like progressive hearing difficulties over the past 2 years. He noticed that he was declining to hear the voices when he was in a very noisy restaurant environments or even during the meetings, but he had no family history of any hearing loss or any genetic conditions. Also, he didn't have any tinnitus, dizziness, or any ear pain. So when we did the testing, as here on my left side, you can see this is the audiogram, which I explained earlier. So he was missing, like there's a dip, like a cookie bite. We call this audiogram as cookie bite because there is a dip in the mid frequencies. As you see, 125 to 16,000 is like from soft frequency to high frequency. The -10 to 120 is like loudness, which is like soft to loud. So our conversational level is 55 to 65 dB. And if this person is having this kind of hearing loss, he's definitely not able to hear if he's in, as he explained in his thing, that he's unable to hear in the background noise and during his meeting, like a group conversation. Four people are talking, definitely you're not going to hear. So what prevention can we take so that, because right now he is missing social gathering, so he'll be more isolated. He's having difficulty with his job because he's unable to do groups, meetings with his boss, or he's having his job at a very controversy situation. So what do we do in these cases? So either we could fit them with a hearing aid, and let me explain what hearing aids are. So hearing aid is basically, it's an amplification device which goes right into the receiver, goes right into your ear, and it hits behind, or there are different models of hearing aids. So which amplifies the sound through the microphone, and that delivers the information to your brain. But one thing what people always ask me is like, oh, so right now, if I put the hearing aid, my hearing is cured. Unfortunately, no. Once those nerve cells are damaged in your cochlea, it's irreversible. I cannot do anything to reverse those because there is no cure for hearing loss. But whatever the hair cells are active, they can still function and they will be able to safeguard the remaining hair cells from further damaging because there's continuous additional stimulation from the hearing aid, and that will lead the patient not to have any cognitive decline or dementia in their geriatric age life, in their age-related things. Or else, if the hearing was lost too bad, like more dipper than what we have seen in this case, I would go recommend with cochlear implants. So a cochlear implant is basically an advanced medical device that bypass the damaged part of the inner ear, and it stimulates the auditory nerve so that the information can go directly to the brain. So the hearing aid basically amplify the sound, whereas but cochlear implants, they will convert the sound into electrical signals that the brain can interpret. So this is another case who is a 32-year-old man who described his dizziness was unsteady and that caused him to feel off balance. He has the symptoms from 7 to 8 years, but once he got contracted with COVID-19, his symptoms became like really awful. So he was associating his dizziness with more pressure, tinnitus, had loss of balance while walking, had a blurred vision and weakness in his arms. He also had back and neck pain, was recently diagnosed with convergence insufficiency. He also had a clogging in his left ear due to ear infection, and he was having constant ear infection. So he was treated with PE tubes so that um, there is no issue with the fluid buildup in his ear canal. And then he had bilateral tinnitus, earache, and fullness. And when we sent him to an MRI, because he was having dizziness with that high stage, the imaging came with inconclusive, with also like possible diagnosis with superior semicircular canal dehiscence. I'm going to just show the video of how we do the vestibular testing. So this is where the man is wearing a goggles. That goggles tracks your eye movement. So if there is, whenever you change the head position or any movement of the body, the eye will produce nystagmus. If you are having any semicircular dehiscence, you are gonna have a nystagmus in your eye movements. That will let me know on progresses of how we do. It's a lot complicated. I'm just going with very simple definition here, because once you learn vestibular steps, once you come into our program or you do audiology in your future, that has a big area of continuous right now going on. So then when we did that, the clinical findings is, as I said, there was abnormal VNG testing, which is video nystagmography testing. And the position, what the results we got could be a possibility of benign paroxysmal positional vertigo, which is nothing but when the person is moving their head from one direction to other direction, or even getting up from the bed, they're in the semicircular canals in the utricle or saccule area, you have otoconia. So whenever you move your head, the otoconia get displaced into a different semicircular canal, which that is not their positions to stay. That's when you will feel that your whole room is spinning or your whole area is spinning, or you can't walk. You need to hold on to something, because some people do get really, really bad dizziness, or even they throw up after they get nausea or vomiting sensations. So our recommendation was Eppley maneuver, so that we could change the head position and get the displaced otoconia to the place where it's supposed to be, and then also have a vestibular rehabilitation therapy, which would be with the physical therapist, so that at least whenever there is a light, or because it takes a lot of time for the otoconia to get displaced in their regular positions. And also sometimes there is coffee or alcohol which trigger these movements for some patients. So a lifestyle modification would be one thing which we would have recommended. And if I go with this is the next one, which is intraoperative monitoring. So this is right now in USA, you can do a specialized certification for this. What you do here, I'm just going to give a gist and then we'll go forward and explain. So here you work in the OR with the patients. You are basically working with the working with the surgeons over here to monitor the central and the peripheral nervous system of patients who are undergoing the surgical procedures. So you basically assess the function of the nerves, or including like the spinal column or the brain regions or the peripheral nerve during their surgeries. So this neurophysiological information doesn't just not just like you're not monitoring, but also helping the surgeon to perform a safer and sometimes more thorough procedures. As sometimes some patients, once you do the baseline, you know that this thing is working. When they do the spinal surgery, suddenly you see that the baseline has moved and you are not able to. That means there is some paralysis or there is something happening with the nerve. So you can definitely alert the surgeons over there, and you can be careful, because that is a nerve which is going to get affected and it's affecting. So what we can do to get back to the positions. So this is a very critical, more anatomy, more physiology. So you need like a special certification. And I'm more interested in this field. I'm going to take my fellowship next year for this course. So which is really, I'm more into this. If on my right side, I'm just showing the video graphs of you work with mostly neurosurgeons or even orthopedic surgeries. You work with ENT surgeons with the cochlear implants, where you connect all those electrodes and you test their nerves. Where can we work? My profession, it's a wide area, and wide areas where you can work. You can work in hospitals, ENT doctors, rehabilitation center, either schools. You can also work in the research industry like pharmaceuticals, an ototoxic research industry. You can also work in a military, and also with the telehealth, which came right when the COVID started 5 years before. That's when more telehealth and remote audiology has started. And also with the corporate structures, which is like more forensic, where you're working with more industry setup. So if there is a, like I would say, if there's a person who is having hearing loss because he's working in a mine factory or something, and he has hearing loss, you basically make claims, or you take care, the company gives you the right to take care of that patient, so that they are being helped with all the disability work. And in our profession, I would say we are like a multidisciplinary approach, because we have to give best patient-centered care. So we tie up with ENT surgeons, speech language pathologists, occupational therapists, physical therapists. So occupational therapist and physical therapist is basically with the vestibular therapy. They help us, or we work together on what interventions to be made for the dizziness patients. And during my, I would say, undergrad or my graduate, I was more with hands-on practices, shadowing universities or the doctors. I was going with like Weill Cornell Medical Hospital. I did in some few private practice just to get an idea as a whole, because the more you get the approaches, the more you're able to get your thoughts in what you like, what you don't like. Because this area is not just you're just treating one patient and done, or just you're doing diagnostic and done. You can have reversal role, and that's what I love in this profession, is because I can have like be in a hospital, do my thing, but also I can have my private practice where I'm doing something else. So this is what I love about my profession. So how my typical day would look like: as soon as I get in the morning, I review my patient's charts, records, prepare my schedule for the day. So once that happens, I set up my diagnostic instruments, either for audiology evaluation, vestibular testing, or even for hearing aid dispenses. I have to update the profile. So my day never goes like, okay, I'm just gonna treat one kind of patient. No, I have various type of patients every day. So either it could start with like examining and assessing patients with ear-related concerns, or diagnosing their underlying causes, medical causes, or I could be performing ABRs or OAEs for pediatric populations or difficult to test population, or either be fitting patients with hearing aids and provide instructions on how to use them, what they are able to do, and how to maintain them. And also counseling the patient is the most important thing on how to take care of their hearing difficulty and what alternative measures they could use to even be with their closed ones. And by the evening, I have most of my time is monitoring the patient treatment plans, assess their progress, and address their concerns, and conclude my day with documentation, follow-up, and coordinating with different healthcare providers like neurosurgeon, ENT surgeon on what are the results we are seeing and how we can proceed further for the medical intervention team. So if, as everyone said, like some people are from Qatar, there are different admission process. Right now, I have for both. So right now it is in USA. I would say like if you want to apply for a Doctor of Audiology program, you need to have an undergrad degree in communication science and disorders, or even if you don't have, you can take a prerequisite course, work in anatomy, physiology, or physics, and you can still apply for this for this course. You need to identify your universities, which are under American Speech Language Hearing Association. This is like the main organization for our course. Then you consider factors on what locations you are, program structures, clinical rotations, what are the research opportunities the university is providing. Because when I came to US, I'm a person who does both clinical and research. So research also helps you a lot to learn what's happening, and you can bring your research into the clinical field, which is what I love the most here. And then you think about your tuitions and funding opportunities. Universities have scholarships. You can apply for those, or graduate assistantship or teaching assistantship. So there are some universities you need to take GRE, some not. After the COVID, some universities are canceling it. So every university has different kind of application. So either you take a GRE or you don't, according to them. Then you submit your official transcripts, letter of recommendation, statement of purpose, CVs. If you have shadowed in your undergrad, or maybe like right now you're undergrad, you just shadow or clinical hours. If it is available, you give them that information. You also, if you are an international student, like if I was before, I had to give a TOEFL, which is like a non-native English speaking exam. If you're international, you also have to convert your foreign transcripts by the World Education Services, so that your transcripts, because some country has percentage, here they will convert into a GPA structure. So in that way, later all the universities require that. So that is the main you need to do. And then some applications are direct university based, or some are through the SEDCAS. There is an application platform. All the universities would be listed who come under that, and you apply through them. So it's one platform where you can apply. And once you are selected, you either give an interview in person or virtual. Sometimes if you're international, you do a virtual one. And that they want to see how motivated you are for this education, or what are their clinical interests, and how use your communication skills. Because when a patient is having a hearing loss, it's a lot. It's just not simple like, oh, this is what, because once they see like they're not able to hear, or they're not able to do this thing, it's denial stage is the first stage. And counseling is like the most important in this. So that's why you have to be more passionate about joining this or doing this course. And then I would be talking about if you are in a different country, maybe it could be UK, Canada, Australia, New Zealand, even in Qatar. If you want to do this audiology program, you need to have your bachelor degree in communication science and disorders. There's a difference between USA and other countries. In USA, this is a doctor, so it's a 4 years program. But in other countries, it's just master. So US is the only country which has the doctor program. So the other countries is masters. You don't need 4 years, just 2 years of course. So you need no need of GRE. You need a competitive GPA and a letter of recommendation from your professors. The CV, the official transcripts is all the same. And then once you are done, you need a provisional licensing exam to practice. If I would say what would be your pre-tips as a student, I wish someone would have told me before for 4 years. I would be happy to listen. But in this profession, it's basically it's a very commendable choice, offering the opportunities to make a significant impact on some individuals. It's really, really good. So you also engage yourself, like shadowing more preceptors, I would say, or like your professors, to see how they're counseling, how, because it's we as a starting, I would never say that, oh, I was very good with this. Never. I used to shadow more professionals. In that way, I learned how to approach or how to even counsel the patients, which is really important in diverse populations. And participate in clinical hands-on experience, which allows you to apply your theoretical knowledge in a real world setting, and that also develops your clinical skills. Also interact with patients, collaborate with different healthcares like ENT doctors or neurosurgeons, or even radiation oncology, because there are some patients who have chemo does show hearing loss. So develop both verbal and written communication and counseling skills, which is very important. Cultivate a strong critical thinking and problem solving abilities to assess and address, because this is the most important on how you would treat a patient. That's what it comes to the end of the day, how you're treating the patients. And working with individuals who are experiencing hearing loss requires a lot of compassion and understanding. So developing these qualities will enhance your patient care and also the patient satisfaction, which is the most by the end of the day. So you can take a screenshot or you can reach me out if you have any further queries. You can email me on my Mansi Roy at beyondtheyear.info, or you could even connect me through LinkedIn, Instagram. I'm available in all everywhere. Then stop sharing.
Wow, that was an awesome presentation. I definitely loved learning all that information. I got my bachelor's in deaf studies, so I also am somewhat in that realm, and very much enjoyed it. But I'm more on the sign language aspect of it. So I was curious to see that in your day to day, you did mention sign language a little bit. So maybe that would be my first question. How often do you deal with kind of the sign language world?
So in my world, I usually hardly deal with them. Basically, what happens is that they just come for their regular checkup, like okay, if they need more, they come, they get their hearing testing done to see if it is still stable or not. So I basically don't deal with them. Just their testing part would be done by me, but not something like, I myself is still learning sign language, because there's like a very I would say like misconception where an audiologist will be like just like treat deaf culture, but no, it's not the same. So deaf culture will have they will love they will learn their sign language basically from their ASL preceptors, school teachers, or special educators. In as an audiology field, you just treat them, see if their hearing loss is doing the same, or if they have any, like sometimes they have fluid. You just treat that part. You are in more in like diagnostic setup. The ASL or ISL or any of the sign languages comes to their special educators.
I figured. I was curious though. Sometimes
Oh,
people
like
surprise you and they're like, "Oh, that's my big field."
I know.
My other question was, I know you were talking about hearing aids, and you said that, once the hair is in this cochlear damage, then there's no repairing them. Is there any chance that with the kind of amplification that the hearing aids are having, are that is going to cause any more damage, or is there a way that they kind of remedy that?
So hearing aid is not causing more damage. Instead, it is, like as I said, it is gonna stop the damage, because once you are able, so when you're not able to hear, your brain is not stimulated. So the nerves or the fibers die down, right? So but once you're wearing hearing aids, you are stimulating the nerves which is still remaining. Your neurons are firing, your brain is more activated. So it's just an amplification device for us, for the patients to like just whichever the sound they were not hearing or whatever they were not hearing, just to amplify that and their brain to function more. So it doesn't, like, I would say, like, it doesn't cure their hearing loss, but it amplifies them so that they can hear and they can understand. And pretty so many patients do good with them.
Yeah, I have a few family members that are very pro hearing aids now.
I know. Yeah.
It's been amazing. I mean, you can control so many little things on them.
Yeah. Last week there was a patient, and she was single-sided deafness. One, so her right side was like completely great normal hearing, and the left side was like completely like she was unable to localize. It was like profound. So when she came and she was like wore the hearing aid for the first time, and she was so happy. Like she was like, when I'm walking or when I'm going in a gathering or someone speaks from my left side, I can't hear, so I have to be like, what? So she was like having very isolation in the parties when she wore for the first time, and she was like, oh my God, I can hear them. And even her daughter was speaking from the left side and she was able to hear. She was like, oh my God, I just love this. And there's still a stigma between the patients. I would say still people have a big on stigma, like, oh, people can hear my hearing aids. But the first time she was like, give me a pink hearing aid. I was like, okay. Like she was like, I'll wear a ponytail and I will just show to the world that this is like I'm able to hear from them. I'm like, I definitely need a picture with this, because the way she was more enthusiastic, I have seen like very hardly patients coming with that face to me.
Yeah, that's it's just the kind of the same with some people just don't like braces and they don't like colored braces, and other people have the rainbow.
Yeah, exactly. That's true.
So when you went to school, did you know that you wanted to be an audiologist, or did you have like a different path?
Okay, so I always wanted to get into a medical field since the beginning. Like I was a preemie, so the doctor said like she's gonna have like speech or hearing disability or disorder. So my mom was always tensed about that. But then, yeah, I never knew until I did my 12th grade. I never knew that I wanted to do this field. So I was just surfing more and more about what I want to do. And I always wanted to be a doctor in one of the fields. So I went options. When I saw this, it was something passionate because this course is still developing. More people don't know on where to go, what to do. So I was like, okay, let me try. So when I studied in India about this, and then I got to know more and more deep. So I gave like a 1 year time where I just want to understand if it's my area of interest or not. So I went to schooling for an year. I was like still in the first few days was like, what's happening? Because I did also in speech and language where I see kids with autism or intellectual disability. So I was like, okay, this is a lot. So treating them is also something which is like really, really, you need to have a lot of patience. So I was like, what's going on? So it took me a time. So first 2, 3 months, I was like, oh, I don't think I can do it. But then I started falling in love slowly. And then I was like, okay, so I'm gonna go more with this field. And that's what drives me to US to get more opportunities. And that's why I was here.
That sounds like a great story. Did you have a specific reason why you picked your state and location versus trying to go somewhere else, or is that just more acceptance based, or?
I was more into like a diverse community to serve, because also like I volunteer more in the community services. I am more active in community services, or I'm active in like research field. New York is one top area where it's like metropolitan city, which is like you can get diverse opportunities. So that's why I loved choosing this place. I had a California thinking too, but then I don't know, this place dragged me more.
Coming from California, I'm very excited to see the East Coast more because I've not really been over there.
That's true.
Was there anything that you didn't expect going into your field?
The challenges, the complications, those were like, I didn't think that would be so much once you are in a course which is already developed. Like if you go with Doctor of Medicine MTs, or if you go with the regular physician, it's a different way. People know you, people recognize you. But once you are in this field, people don't tend to recognize you, what you do in the background. But there are some people who tend to recognize you. So, how to challenge and how to advocate myself in the field, that was a big thing. I didn't even think about it.
Yeah, that makes sense. Another question that I often get from people is, did you ever experience burnout, or do you know how, or do you have any advice on how to kind of stay away from being burnt out?
So, definitely burnt out as there's all the fields. I do get burnt out because when you travel, you leave your parents, you come here, you're all alone, you're doing everything by yourself. It's a lot of burnt out. But what I do basically too, that's a very good question too. You put me in thinking today. So in my time of burnt out, what I do is like I give myself a break, which hardly I do. I cannot sit still. I'm a person who doesn't like rest my brain. I'm that kind of person. I have to keep constantly doing something. So when the day comes off burnt out, I just like escape from the world, shut everything up, just take my any like book, read fiction or nonfiction on anything. I keep reading, or I just like to cook or like to travel. So I just travel, like keep close everything and just travel. And if I say like what they should do of not getting burnt out, well, it's a profession. If some days are like, if my OR days are there, you can never, either there are sometimes I have seen patient, I have lost patient during the OR. You never know what's happening in the spinal surgery, something like that. So, there are, I would say, like keeping a mental checkout every day by the end of the day, like what was good and what wasn't. Like, there are some days which is bad for me too, so I try to look more towards the positive side rather than looking for what happened, what couldn't be controlled by me. I look into that, do a daily check on my own self, on my own emotions, which helps me to not get like excessive burnt out by the end of the like every week.
That makes sense. I always felt like finding new ways to treat burnout because I'm always busy. Always doing something. Do you think that there's anything that you'd be excited to, or any condition that you'd be excited to kind of do more research on, or try to innovate in some way, that hasn't been looked at yet?
So, yeah, there are like, I would say like my field has one thing top is like you can do a lot of research because still the research is like still going on and it's a developing course. You can get something like you're still doing. There are some recent research about the gene therapy or, just how we can save those nerves. Like as you were talking, you asked me a question like if those nerves get damaged and is there anything like you can get back? Unfortunately, there was nothing, but they are speaking of gene therapy, and I would like to like do more research because I'm more into like brain auditory experiences research more. So in the past, I did a neurophysiological, but we couldn't get more data into it because the subjects you don't get often. So I was like, okay, I took a break for that research, but I would definitely love to continue it in the further in my future.
That sounds fun. I'd definitely be more on the genes side of things.
I am too.
Do you have a favorite patient story that you think back on?
So, my favorite patient would be I still like when I was in my undergrad, that baby was like so cute. Uh, the patient came, he was a newborn. When they did a hearing testing, it came like it was refer. So it says in their or OAEs that it was refer. So I said, okay. And then the mom came, she was like really crying her heart out. I felt really, that was like, I was in my undergrad. I guess it was in the fourth year of my undergrad when I was like about to finish and trying to prepare myself for US. So I was like, she was burnt out and everything. And she was like, I don't know, this is my first kid and he's having this issues, what to do. She was like very nervous. So like when we narrowed down the options, we did. The kid was 1 year when he got the cochlear implant. So he undergone like hearing aids, did therapy. Then the government funds. So once the government funded, we got all the applications sorted out. I was there for the whole procedure. That when the baby we fit the baby with the first hearing, like the cochlear implants, and he was able to hear his mom voice, that the way the mom like held us, like she just came and she just hugged so tight. I couldn't like she the way she came, I wasn't even expecting, but the way she came and she hugged and she was like, having her happy tears, that was the life changing what drived me like more into like how to advocate about this course or advocate people to like, because that thing is so like pure that no one could take away that happiness from me.
Wow, yeah, that's definitely one of my favorites are all always like emotional things.
Exactly.
Kind of push you to do more things than maybe you thought you were gonna do. Do you have any thoughts on kind of remodeling or changing the way that people either view audiologists or the way that kind of the training or the ideas are around that?
So I would say like I do not have something where you can change, but I also definitely would say like if they are like other countries, if I say like US is still developing, and imagine if US is still having this developing and still are able to like whatever the opportunities we have here, the other countries is like far below that. So I would say like as like World Health Organization or the ASHA or all, they should like meet or have one organization so strong that everywhere the people can get the same opportunities. It shouldn't be like they are, because more opportunities is for the patients more than like more than like our individual. I would say like the patient centered should be in that way, that everyone should keep getting more and more services, because and also awareness. I still believe there is a lot of lack of awareness in this field, that most of the patients don't even know that if there's a hearing loss, you have to go to an audiologist until and unless. So the more improvement it happens in that, and the way if they like when they're coming to us, we are able to. So recently, Maryland, if they come to us, we could order the MRI without even having an ENT doctor next to us. We could do so. These kind of little changes, which is happening right in the field, is also something really great for us to like even like speak out loud, where we like, okay, we need these kind of things. Whereas I have seen like one differences in right now where I'm shadowing PA. There's a PA physician assistant who is with the ENT doctor. Like they are able to like prescribe or something like that, even like the ear infection. But when it comes to an audiology part, you are like you study more than having a PA degree. You study most of the things, but the way they still keep the things like narrowing down from us, that's something I basically we are more vocal on that criteria, where you can like you are there in the medical team just in the big hospitals. When you're there in the big hospitals, like when I did Weill Cornell, the PA had a different role. We had a different role. We were like kind of more superior one. But when you see that in a small clinic, they take over the role. I understand like more physicians or they don't tend to stay, so they more physician assistant stay. But the way I feel like sometimes they give a wrong information. They hardly know what's going on and they give that. And I'm like, that's not what it is. You like, I understand you're giving something, but the way you explain, it's a lot I would say education between the PA and audiologist is also very important, just in case for them to know what's the real background rather than just jumping in a conclusion and saying something which is not even the case.
Yeah, that's like some schools are now requiring you to take bedside manner
Mhm.
at school,
Yep.
which I thought was awesome, but also kind of odd that they didn't really do that to begin with. So
Yeah.
education is definitely increasing. I know you talked about different, I know it's not really roles, but I guess settings that people can work in. Have you worked in multiple different settings, or are you more hospital based?
I love more hospital based because I can work more with OR setups because that's what my love is. So I haven't worked with more like military based or something like occupation based, but with the industry, I always like have volunteered to go and do a hearing test or have volunteered in the services, but I haven't like, permanently worked. My permanent work was always with hospital, but then what I do basically was I volunteer for like a research. I do, as I told mentioned before, I work in a hospital and also do my research simultaneously. And with the other setups, I volunteer to do those services like maybe once a month or 6 months once, so that I am still updated on what's going on or what's not, like keeping myself active on those.
Okay, interesting. I always wonder because I've met a few people in private practice or that do the smaller clinics, but I haven't met a lot. A lot of people are more in the hospital settings nowadays.
I would say people are changing their minds now, more are into like private setups now. Before they were more with hospital based, but now people are tending to, you get when you're in a hospital, the more you have the hearing aid set up, you get incentives and those things, which is hospitals don't do that. So most people try to look down, like look much for that. And that's one of the things which is like, going diplomacy between the hospitals and the private practice, because they get like the money setup would be like thinking is a little bit more because you get incentives. And that's where your patient care might go up and down. So, which is why there's like still a debate on what's happening, what's not, where should you, like your patient skill is what more important, but the industries.
Interesting. Well, I did mention the bedside manner. Do you think there's any kind of skills or personality traits that make you a better audiologist?
So, I would say like to be a better audiologist, you should have like first thing is like good like counseling and the communication skills with the patient, because first of all they are having hearing difficulty, and if I just be like, okay, I'm talking to you, definitely this is not gonna like help them. So able to approach them in a way, because most of the people in their family is like either shouting at them, I would say, because they can't hear, or thinking like, okay, either he has like gone like insane. I would say like some patients wife would be like, oh, he has gone insane, he's talking like this. I'm like, approaching them in a very good way is also like taking care of the patient, with like giving them that comfortness to listen to us or even talk, open their minds out or talk to us, is something like I would say is the first bedside manner, because that's like more and more important. With the vestibular, when they have like more dizziness and you're doing like bedside vestibular testing, there are occasions when they are like nausea, vomiting. It's all cases. Staying still, because there are like a lot times when they wouldn't have had that feeling, but they just threw up by mistake. But sometimes people don't take it in a good way, and sometimes they are like very rude to the patient after that. So making sure like you comfort the patient is always like the best bedside manner, I would say. And that would also determine the best audiologist.
Yeah, that makes sense. I definitely have some friends that have grandparents that are like, oh, he's just gonna sit in the corner because he doesn't hear anything.
Yeah.
I think is kind of crazy because do you think hearing loss is extremely prevalent in older generations? Or do you think that, I don't know, that it's kind of a 50-50? What do you say that kind of progressive hearing loss has been?
Yeah, with older generation, I would say like it has been like 60-40. Most of the patients I'm seeing these days are having age-related hearing loss. And also it could be like maybe they had hearing loss since the beginning, and slowly, slowly as they aged, it progressed more. There are patients like that. Or also there are some patients after 50s, they started declining very low. Because I saw one patient, 106, God knock her. She came just she was yeah one of the patient was 95 years old. She got her cochlear implant done because she was like, I'm unable to hear my people, so I need the cochlear implant. At that age, we were like, I was really scared. I was like literally crisscrossing my fingers and praying to God, like, please, because 95, sometimes, it's temporal bone surgery. I don't know what's happening. It's kind of was really risky for us. But we were like, okay, we are happy that she's breaking the stigma, as I mentioned. So she got, and touch wood, she's so good in health right now. She's enjoying her lifestyle. There was patient 106. They came for hearing aids and everything. So basically, I would say there are like patients who give us a lot, um, like I would say like happiness with all these when they have when they're able to like have the communication skills with their family members. So that's one thing like I would say.
Yeah.
That was your question. I guess I somehow missing the question in one point. I went with one story and I guess I forgot the
No,
question
I
you
think you still answered it because I you said 60/40, which kind of does
said.
give me a
Oh,
clue onto. I know what cochlear implants and kind of how they're set up, but did you want to talk a little bit on how it's kind of implanted, what it does and what it how it like works in that regard?
yeah. So, the cochlear implants, what it does is like so one ear will have a cochlear implant and one ear will have your hearing aid, or you can get a bilateral cochlear implant based on your severity. So, when you have like a 1 ear cochlear implant, so they are gonna back of your ear canal, they are gonna like make an incision, because there's like electrode array with the magnet, so that's gonna go behind your ear, and then the cochlear implant will sit right here, and then there's one electrode array which sticks the magnet on the temporal bone, which stimulates all the noise, sound, whatever you're getting. So the one is outer external electrode array, and one sorry, the magnet, and the inside there's one more internal magnet. So that is like sync. So it's like sits like a flap. So imagine this is my inner magnet, this will be my outer magnet. So one is inside my temporal bone and one is outside, so that sticks together. So the whatever the sound, it vibrates, and that, so it goes to my ear on the it passes my cochlea, sorry, it passes my auditory, I would say like the structure. So it goes to the my cochlea, because cochlea is like a round snail, so it goes and the electrode array will go and round into the cochlea, and that will stimulate the auditory nerve, instead of like how the amplification device just moves the sound from outer ear to the inner ear, because their hair cell is so much damaged. That's why we are giving them a cochlea. So what it does is the electrode array will be the one which is taking the role of like a inner ear of the like hair cells. So that stimulates, and that goes to the auditory nerve, and that goes to your brain, so you interpret the speech and the noise, or even the conversations.
Awesome. That's pretty cool. I didn't know you could get two,
Yeah,
weirdly.
you can get two.
Is there a certain age where you wouldn't recommend a cochlear implant? I know these someone at 95 got one, which is kind of crazy to me, but I have heard some people say that you can't get them that late because you can't really differentiate the sounds as well. But maybe that's more for deafness or sensory neural deafness.
So I would say, like, if they are saying that, so basically, what happens is, if you have a dead ear, I would say, like, since your birth, you never ever stimulated it, cochlear implant will not be able to help you to understand the speech. Like, imagine 50 years you have never had any amplification device, you have never stimulated your ear or your brain. So those cells are dead, right? You cannot put anything to activate them. Even a cochlea, even if you do that, it just will help you to like make aware of like, okay, the sound is coming from the right side, or there's a sound coming from left side, only in the awareness or the localization sector, but will never be able to help you understand the speech. For understanding the speech, you need to have some stimulation since the beginning.
Okay. So do you think there's an age that say you aren't completely dead ear, but say like later on you started losing your hearing, is there an age that you think is just not all that safe to get a cochlear
I,
implant?
I would I would say like all ages are safe, but we also have to consider their other medical factors. Sometimes they have maybe diabetes, or they're having some other issues, which is like kidney, or even like the blood thinners. They're on blood thinners, or they have some residue which is more complicated. They can get it, but it's also like there's no promising results. Like, okay, will you, because it's also costing their life a little bit. So in that situations, we would be like taking into consideration very like, okay, should we get it or should we not? Because there is acoustic neuroma or something which is like diabetes, because their health, we have to look as a whole. Hearing is one part, but also health as a whole. So if there are any comorbidities, then I would say we will take more precaution about should we get it or not. But any age you can get.
And would you say 106 has been your oldest patient?
Till now, yes. 106. No, there was one more, 107. So yeah,
Oh wow.
that was still where.
Yeah, I was gonna say you said all ages, but then I was thinking, you did said babies, but I wonder how old.
I have some
107.
patients 107 too. Till that was the last. So I was like, okay, I'm like, God bless them. Whenever they come and they see their age 107, I'm like, God bless you guys. I just knock on the wood. I'm like, God bless you.
Do you think that that's gonna get progressively longer in the future? I'm
So
seeing people say in like the 120s.
so the longer they live, I would say like if you're wearing your hearing aids every day, you do what it has been said, you only see a it's gradual over the years. So imagine if you're putting your hearing aid, starting to put since 100 years. It takes like, or maybe 106, as my last patient was. It takes years and years if they're amplifying their hearing well, and their hearing aids, they're wearing, they're doing everything, whatever we suggested. It's going to take years to have like a progressive decline or a gradual decline. It would have been like 5 dB maximum here or there, but nothing more than that.
I meant more, do you think that with kind of gene therapy and those kind of things that we're gonna get steer more out of the cochlear hearing aid side of things and more towards trying to like actually fix the inner parts of the ear that are having that trouble or problem?
So as I would say, like gene therapy just started since, I mean, it didn't even start. It just right now they're researching about it.
Yeah.
So I believe once gene therapy comes, it's basically gonna be more towards the sensorineural hearing loss. And as it's just very new to the field, so there are no promising results on what's gonna happen, what's not. But I am also more interested in that. So I was thinking of like, because I'm starting my residency in Thomas Jefferson University, where you see more robotic CIs, and you also like work as a collab team with all neurosurgeon, ENT surgeons. So I am gonna start over there. I'm like kind of more, they also like have a good research center. So I also myself was thinking about with one of our professors want to start with the gene therapy to see what kind of, because I am going to see a lot of different kinds of patients in vestibular, in cochlear. There are different going to be a patients. So I'm kind of like more towards that thing, and more I able to discuss. Maybe I'll tell you one day.
I'll see your name somewhere.
Sure.
Have you published any research?
I have several research. Yes, I have almost 10 to 12. I have attended multiple conferences. Yeah, I have done a lot of research in brain. My main area of focus is always either vestibular or cochlear or brain electrophysiology or neurophysiology.
Okay, that was gonna be my other question. Has any of that deviated from the ear at all?
So basically, no, I still have to find a relation between the ear and the brain, because, ear is so important. People always tend to forget, like when you don't hear, that's something missing out. I understand the other body parts is also as important, but sometimes I feel in patients I see, they don't care about their hearing, but they care about their heart, they care about different other features in their body, but they just miss that very simple organ of their body. So I would say like it never deviated me, but it always like had a connection, because whenever I have to portray myself, I have to always connect to what my field is, because this field is small. I want to make it more bigger. So that's the thing.
So I know that you talked a little bit about stigmas. Do you think you have any biases in your field?
I would say there are biases in my field, because sometimes people don't want to like just don't want to get it. They just like deny the whole process. And because they think that whatever they're doing, because I can give you an example. Like there was a one professional who came to us, was like 8 times, and wanted to meet all different audiologists in the same building. And because whenever we said, oh, this audiologist is available, never made the appointment with the same audiologist. And when we had like it was in Weill Cornell, and they were like, we had 5 locations, so went for all the 5 location, all different. Everyone said the same, because we can see the chart same, and we have been he had taken several opinion and went to different places, because we used a system where if they goes to a different hospital, we can still track them in this. And Epic was the we could still see him going to Columbia or this. And we were like, why are you going? And like he would have met like 100 doctors right now, but still like he wasn't able to accept that I had a hearing loss, even though every thing said like you have a hearing loss, you need a hearing aid, or we could help you in this, but never. And the main problem with that patient was the stigma. He never wanted to wear something which was outshone, because like, oh, I'm a businessman. People are gonna notice that I have a hearing aid, so they're gonna take me into a consideration that I'm not strong enough for the field, or I'm not powerful to give a command. People will take that as a weakness in me. So we all had a session. We literally made that patient sit, and we were like, you have to break the stigma. To break the stigma, you have to do these kind of things on how would you be able to, even though you have that hearing loss, how are you gonna portray your work? Because people want to care about your work, not about what you're wearing in your ears or not. So with multiple sessions of oral rehab and things and everything, that patient was like finally accepted to wear a hearing aid. Went with multiple models, because there are some hearing aids which you can just wear inside your ear. You people can't see it, but also there are some others. But the way he had a hearing loss, he needed a little bit different, which could be more visible to the other patients. And then cosmetic reason is one biggest stigma, I would say, for hearing aids. And if I like, there are like multiple cases, I can talk long and long on those, but that is like one thing which biases is like sometimes women's, or I would say like more men face more, because women, they can hide it, pull their hair up. So the men is more who is having a more difficulty with the stigma more. That is one thing.
Yeah, I could see that. Do you think that since you mentioned different models or different styles, do you think that wearing one that's ill-fitting or not really helpful, is that still somewhat helpful for your hearing? Or is there really truly like a specific model that specifically helps and
So
one that doesn't really?
So I would say there's nothing like one helps and one doesn't. Every model, whichever you purchase, will be helpful in either way. But something is better than nothing. I always say this to all the patient. Like, even though if you don't want something like visible, but even if you're ready to accept that you have a hearing loss and you want to wear just like in the ear hearing aid, take that, because that will keep, it might not stimulate 100% of what your hearing loss is, but at least it's going to reach to 80% of your stimulation. It's going to at least activate your brain. The nerves are not going to get damaged. You're not going to get progressive hearing loss maybe after 1 year or 2 years. That will slow down your connection with the people might be difficult, like, being in a noisy environments or walking down the noisy streets, that would be difficult. But you can still conversate one to one. You can still have your other activities, whatever you do, consider it like, okay, like, because I have been internationally, nationally, I see people in my country, India, where I'm coming from, I had more difficulty, but I have not, since in India, like 3 years, 4 years, I haven't been there. But so basically now I don't know how the acceptance rate is, but US, I still see more acceptance in their hearing loss. There are a few patients here and there not, but more acceptance have been coming from US till now. And other countries, when I talk to my friends who are in different setups just to see how their country is doing and what we can, share, I see like acceptance has increased since the beginning, the time I was studying my undergrad until the time, because we give 8 years of our life to this education. So acceptance has come far, but not that far where I would be like, okay, you have a hearing loss, let's wear a hearing aid. It's not like that. So it's still a denial phase and everything goes the process.
And then kind of my wrap up question. A lot of people ask professionals on these is I know you mentioned shadowing. A lot of people also talk about mentorship. Do you have any good advice or ideas on whether how to find shadowing or mentorship or how to request that or kind of how that worked for you?
So I would say that like I can be a best example for that, because whenever I am into this field, I like to talk to the professionals. Like, if I see like there are 5 or 6 professionals, or five, six audiologists, I will just go to everyone and be like, listen, I'm interested in this field. I want to see more. I want to learn more. Can I observe? Maybe the time, like, if I start my day from 8 to 5, maybe they don't do 8 to 5. Maybe they are more in OR, so they are different timings. I have to give my Sundays or my Saturdays for that. So what I do is like I do my work like as it is scheduled, but also if I have to shadow or mentor, I would reach out to all the professors. This is how I did my shadowing, like more and more learning skills. Also did more research. I never have a off. Saturday, Sunday, I'm working every time, which is a hard thing, but yeah, I have like no days off in my own life. I keep doing, like, today I was basically supposed to be off, but then today I took research in my hand. I wanted to get more connection to the people or advocate the people of my course. So I take like every simple day into like more mentorship or leadership qualities, and I reach out to all, even like to the people who are right in this meeting. I would say like reach out to your professors, reach out to your preceptors, whoever. They will, the more you try to engage with them, the more they're happy to help you. They will open their doors more and more. The more you're quiet, because I'm an introvert, I never used to speak more, but I saw like I had to break my stigma to confront and talk, and to open like my eyes, where I'm like, listen, I'm interested in this. What can I do to reach there? Or can you help me? There's no problem in asking a help. I used to be like so scared of asking help. But once I started doing it, I saw people being genuinely happy to help me and happy to place me in the OR or able to observe the surgeries. And I learned a lot on those days. So I leave my Sunday and Saturdays only for these things.
Awesome. I love that. I'm definitely one of those reach out to everyone.
Yep.
I've been building my net and I'm definitely an introvert. I call myself a professional extrovert.
Okay. Maybe I could use that term next time.
Oh yeah, yeah. I forget who I got that from, but I got it from somewhere. So
Now you get me used to that, because really I was so silent before. I never used to, like, if someone says me something, I'll be like just gulping it within myself, not even saying anything. But then I was like, I'm not gonna live like this. I cannot make more connections. And I used to be so scared to even tell what my opinion was. But then now I can be like, if I don't like something in what's going on in my field, I am at least having an opinion to like tell like, don't you think this would be this criteria? But sometimes someone is overlooking something and I'm able to put my voice in and treat the patients. By the end of the day, that's what is needed for me. Like I can sleep peacefully in my bed. That's what I need.
Yeah, I definitely agree. Well, thank you so much for your information and your presentation. I think we all learned a lot. I definitely learned a ton. I'm just going to finish up with my little wrap up slides. Something that we always recommend during our wrap up slides is to reflect on um, anything that you really thought about that was meaningful in this presentation. We have three questions that we usually ask people is what brought you today? What's your three major takeaways? And what do you want to learn more about? I know that Dr. Royce did publish her ways to connect with her. So if you had questions for her, you can always message her if you didn't want to message them today, that's perfectly fine. You don't need to send these, but if you do want to send them, we do sometimes publish these on our LinkedIn page. And so if you wanted to send that to info@prehealthshadowing.com or even just tag us in a post that you made on LinkedIn or Instagram or anywhere, we are always happy to look through those. We do have them posted online, so if you want to see what other people are saying, and kind of get a feel of what you should be writing about or kind of the examples that you might want to share, always an amazing way to kind of grow your network. You can always get people that are seeing your pages more, especially on LinkedIn. You definitely want a great presence on that. So again, if you're interested in being a part of pre-health shadowing, we have so many different opportunities and so many different things to do. It depends on your skill set, depends what you want to do. We are 100% remote. The application is online. If you go to prehealthshadowing.com/volunteer, you can go and fill out the registration form and you can kind of see what questions that are asked on there. We do ask kind of how many hours you want to donate or give to us. That's fully up to you. You can do it an hour a week if you wanted to. So there's no pressure there. So if you do want to keep track of your hours, we don't really do that right now, but get rid of that. If you can donate, again, the QR code's on here. We are always happy to have donations, even if it's $5, or even if it's your time. We always love more time. More time definitely helps our program a lot. So if you can or can't donate, that'd be great. You can always provide this to your friends or family or other people that are also in the pre-health world or in the health world that are looking to kind of change some opportunities for other people who are trying to get into that world. So the moment that everyone's been waiting for, if you want to get your certificate, I mean, I'm sure you do, is you'd visit the course page. It's where you got the Zoom link, so that should be pretty easy for you and actually should still be on your screen if you go to another tab. Then you go to prehealthshadowing.com and you can just sign up for this course. You probably already did that to get the link. There's the quizzes 10 questions. It is up now. It's 30 minutes. You have to get a 70%. So you can get three questions wrong. As long as you paid attention, maybe you took some notes, you should pass with no questions asked. But if you do have any problems with that or any struggles, feel free to email us at info@prehealthshadowing.com and we can fix any kind of technical difficulties or we can discuss why you were not getting the right questions. So they're also open indefinitely. If you don't have time to take it today or you don't have time to take it tomorrow, you could take it next week, you could take it next month. If you do forget the info or you wanted to take more notes, we will have this uploaded to YouTube. We try to do that within 24 hours, but sometimes that does take a couple days just because it's a lot of information and it's a heavy download. We are at an hour and a half and then 30 minutes for the quiz. So you will get 2 hours of shadowing credit. At the end, I know this picture says finish course in the middle. It will actually be at the top of your screen. And sometimes there's a banner that you need to exit out of to see that finish course. You do need to click finish course and then you'll get your certificate that you can download online. Again, there's another page that kind of explains it to you. No clue why, but if you want it explained in another way, there you go. If you have any problems with that, though, feel free to email us. I will be on for a few more minutes. If anyone has any questions about our program or kind of what we do, I am very happy to answer any of those. So if you missed anything, again, it's on our YouTube channel at Pre-Health Shadowing. We also have other sessions on there if you want to go and watch those. You can also get the certificates for those. So if you want to go through our laundry list of professionals, or if you wanted to look into different professions that you're more interested in, like I love this audiology profession. I'm definitely more on the psychiatrist aspect of the world, so I'm more leaning on that aspect. But I always love listening to all of these other different professionals, and maybe audiology will be my new thing. Everyone always says you go to med school and you change your major because you find something you love, and I actually did really love this presentation. So always looking into that and looking at different professionals. So I wouldn't stick with just the one that you think is right for you. I'd also look around and see what other ones maybe you like as well. So be sure to catch our sessions every week. Our next one is this Wednesday on the 9th. I don't remember the time, so you'll have to go look at that. I believe it's in the evening. If it's on the East Coast, or if you're in the East Coast, it's probably at night. Evening on the Pacific Coast, that's where I am. But you can look into that. You can also email. You can also go register for the class right now, and then you'll get notifications on that if anything changes. Very rarely does it ever, but just in case. Just so you know, thank you so much for joining, and thank you so much, Dr. Roy, for presenting. I very much loved your presentation. And maybe I'll tell you how my MCAT goes. So I'll email you.
Definitely, I'll be able to try to listen to that.
I will be excited to do that. So if you have any questions, stick around. You can ask me, or you can maybe even Dr. Roy will stick around for a couple minutes. But I think everyone's kind of getting out of here, but if you do, then you're welcome to. Well, have a great one, and everyone have a great day. And thank you so much. And I am going to stop the recording now.